We have an exciting next section. It is called the Treatment Roundtable. And I'm going to call up some of the physicians that already spoke and another one who hasn't but will. Dr. Ewok, Andrew Ewok, if you can come up to the stage. Dr. Ewok is the Executive Director of the Glaucoma Center of San Francisco and a key player in Glaucoma Research Foundation. Dr. David Richardson, who spoke earlier, is a glaucoma specialist from San Marino Eye. I'll have him come up as well. Dr. Savak Taymorian is already here. Thank you for that talk. And exciting, we get two patients to come up here today. One is Nina Markowitz. There she is, come on up to the stage. And one is Ginny Wright, who's my patient. And I'm really excited to have her here. So come on, come on up to the stage. And there we go. So we have a lot of time in this session, and the purpose of this session is going to be to allow the patients to describe their journey through treatment and surgery. And then there are lists of questions that you guys have asked through the QR code that I can ask the doctors and the patients as well. And then we'll start with that. So I'll just moderate that. I'm going to start with the patients first, okay? Because as you know, patients first, right? All right. And they're all mic'd up, and we're really excited about that. Nina Markowitz, would you mind introducing yourself and telling us a little bit about your glaucoma journey and your treatment?
Of course. Hi, I'm Nina, and I've been at this glaucoma thing for about 20 years almost. My journey started off like most people, noticing that my pressure was too high. And went the route of drops, some that I was allergic to, some that I got severe reaction to that had to go by the wayside, and finally found some drops that helped. But I was drop resistant, and that led me into glaucoma surgeries, which led me into other surgeries. And so it's been a journey. My vision is now I'm legally blind. The stage is weird, but I'm still trying to function on my own and doing the best I can, like most of you.
Thank you so much for sharing that. We'll talk some more as we go through questions and your own experiences. Ginny, you're up. Tell us a little bit about your journey. I know all about it, but...
I know all about it, I know. Yeah, so my name is Ginny Wright. I was diagnosed with asymmetrical glaucoma about 5 years ago. It's in my left eye. My right eye is okay, thank goodness. So I was so surprised, but I went to 5 different specialists, and I had 5 different treatments recommended. Laser, drops, trabectomy with cataract surgery, and then I was listening to Amy Dixon and how she was saying that she's an advocate for herself, and that resonated with me because that's what I did as well. So I did tons of research, and each treatment that came up with, well, if this doesn't work, we can wait a month and see how you do. If not, we'll do drops. If this doesn't work, it was kind of like that. So I found I don't have time to waste because I had already had like almost an 80% vision loss. And so I met with Dr. Bedrud, and she suggested that she did the most aggressive that I thought was the trabeculectomy, where she opened up a hole, I think, in the back of my eye and made a little bleb that drains the fluid from my eye. To preserve what I had left of my optical nerve. And so I did that about 4 years ago, I think it was, maybe 4 years. And so my pressure right now without any drops is usually around 7, and it needs to be under 10. So I still have some central vision, so I feel really blessed.
Oh, that's great. I do have to say,
Did I answer that right? Did I say it right?
I mean, that was a perfect answer. It's like you rehearsed
Okay,
that.
thank you. I got 100%.
It was
10 out of
incredible,
10.
and we didn't rehearse it. I promise. You know, and I want to say that Ginny is different. Every patient will have a different target pressure. Not every patient needs to have a pressure of 7 or 8. Her particular type of glaucoma, being low tension type glaucoma, really required that, and the amount of vision loss that she had. So by no means should everyone have that goal. It's different for everybody. She needed that though, and I'm really glad to be part of that journey with her. Okay. Thank you. We'll get back to you for some more of those things. I will say, I do have a question, actually. We had a question from the audience about recovery from surgery. Can each of you describe your recovery from each of the surgeries that you've had?
What did you have?
Sure. I personally have found a recovery from surgeries fairly easy. I've also had trabeculectomies, also had two valves put in one eye, and additionally retina and cornea transplant surgeries. And in each case, I have to say that my recovery has been easy. The most difficult part afterward is no bending, no lifting. As a woman, we carry heavy purses which has way too much junk in them. Having to find an easier way of carrying our stuff has been an issue. I try to be with somebody in the family the first couple of days at least, until I know that my vision is cleared enough, if that's been an issue. But I have to say that the surgeries have not been painful for me in most cases, especially if our doctors remember to clip stitches real close. When they don't do that, you feel like you have stuff in your eye all the time, which is real annoying. But I think it's been fairly easy for me to recover from the surgeries, and I've had good vision results because of it.
Okay, so I think for my recovery, it was also easy as well. My husband doesn't cook, but he makes the best peanut butter and jelly sandwiches. So we ate that for a couple days. But I think also, have to remember always to keep your eyes closed when you take a shower. And you don't want to have any sort of an infection in your eye, which is something that I think of all the recovery, I think worries I had was that I would get some sort of an infection in my eye, and then the surgery for some reason wouldn't work anymore, and I wouldn't have the results that I would want. I think also when you do the surgery, there's always that worry that, as time goes by, will your vision get better? Will it get worse? Will it be constant? Will it stay the same? I think, that all those kind of worries go through your mind, but as time goes by, they all kind of like dissipate, and you ease into like kind of the new reality, I think. Yeah.
Okay, I'm going to ask some of the doctors. Dr. Ewok, is there anything that you specifically tell patients for their recovery, both in preparation for surgery and also recovery of surgery, that you just wanted to share?
Yeah, thank you for the question. Your summary is right on the mark. And I think, number one, you have to be careful not to think that this is cataract surgery, for example. So you may have a lot of friends who've had cataract surgery. They have the surgery a couple of days later. Their life, they're golfing better than they were before surgery. Glaucoma surgery is different. It is by design. We don't want things to heal too quickly. And so this is a real partnership. So in advance, the planning before glaucoma surgery is really important. That you anticipate, look, I'm not going to be able to lift these things. I'm not going to be able to do these things. So that as much as possible in that initial postoperative period, that you can minimize the impact on your ability to do things. Oftentimes, we'll tell you to restrict your activity, and good point about cutting the sutures short. And one of the tips I tell patients is the more you can rest both eyes, and I'll explain why in a minute, the better you will feel and the quicker it will heal. And so there's a thing, oh, I had surgery in this eye, I'm just going to squint it and let the other eye, well, actually by doing so, you put forces on that eye that you have to see to get around, and that's fine. But especially during that first few days, rather than watching that movie, maybe listen to it. And you'll find that it's when you blink across those suture lines that you actually put a little bit of tension on it and makes it more uncomfortable. The best patch is a natural patch, and that's your eyelid. So as you keep your eyes gently closed, that actually will make you feel better, and so you prepare ahead. I'll tell my patients to get some audio books, whatever. Again, you can keep your eyes open to do what you need to do, but anticipating that. Your vision will get worse. In fact, on that first day, if they're seeing kind of close to what they saw the day before surgery, I say, wow, that's great. And it will fluctuate that first month. Fear is a big component in glaucoma management, and trying to empower you to anticipate, if we can tell you, if a pilot, and I may go later on to this, I think about managing glaucoma like in a plane. I don't like to fly, I have to fly. I have a fear of flying, but I get on these planes. So I get on these planes by learning every sound on that plane. The more I can learn, the more at ease I am. And so for patients, making sure it often will be maybe the surgical scheduler or an assistant, that you kind of anticipate, envision what you're going to experience. That reduces your blood pressure, you're more at ease. There's some turbulence, the pilot tells you, we see some clouds ahead, just buckle your seatbelt, we're going to get through this. So those are kind of the things that I do for patients. We lower the pressure. Raising the blood pressure suddenly may increase risk of complications. So we want to talk to your internist, your family doctor. If you're on anticoagulants, do you need to be on those anticoagulants? So you follow me? So surgery is an important step in managing glaucoma patients. So the preoperative evaluation, preparation are really important, and then that also leads to the postoperative course. And that's where it's really important to have that relationship.
Very good. Thank you. Okay, I am going to go through some of the questions. Please, again, feel free to bring the QR codes. I think, yeah, we are collecting them pretty well. Okay, awesome, great. We have a question for Dr. Richardson. For the 15% of people who develop allergy to brimonidine, how quickly does the allergy begin, and does it resolve?
So I've seen both very rapid and kind of a what we call a chronic indolent or slowly increasing. There are things that your physician can see at the slit lamp, so the biomicroscope in the exam room, indicating that there may be an early onset of allergic reaction. Generally, unless it's actually causing discomfort for the individual who's using brimonidine, we'll continue to use it until it gets to that point. For some people, they feel discomfort or bad itching. Others, they'll actually have some redness of the skin around the eyelid. And for some people, it's just some redness of the eye that's cosmetically disconcerting, but not necessarily something that requires stopping the drop for. So, that 15% of people who develop allergy is not 15% who have to discontinue the medication. But it is one of these things that, although not the majority of people who take the medication, it's a large enough minority that it's important to be aware of. If you do ever suddenly develop red, uncomfortable, teary, itchy eye with tender eyelids, that's something that you should let your physician know about. Then hopefully there will be another class of medication among the ones that I discussed earlier that we can switch you to, or perhaps discuss some of the other available surgical options. And again, it's really important to emphasize that the surgical options, there's such a broad range, right? That some of them you wouldn't even think of as surgery, right? The selective laser trabeculoplasty, you come in, it's quick, it's done, it's painless, and you think that was surgery? Wow, what was I worried about? And so, we've got the one extreme, trabeculectomy, glaucoma drainage devices. We've got other extremes. The important thing is, good communication with your physician if something's changed. We'll bring in, take a look, and modify the treatment according to your needs and what's available.
Great. All right, Dr. Tamorian, there's a question for you. If a newly diagnosed patient can get SLT a few months from now, should they take drops in the meantime or no drops so they're treated first with SLT? That's a great question.
It's a good question, and unfortunately it always leads us to it depends. And I know we try not to be like ambiguous. It depends on the patient. If the pressure is higher, it's more advanced glaucoma, and we really need to delay the laser a couple of months, then I would start them on eye drops. I wouldn't wait. If the glaucoma isn't that advanced or it's early, just high eye pressures, not really a family history, we just want to get the pressure down and we have to wait, I wouldn't even put any drops in because I know the side effects of the medication. So I think the question is, it depends on the patient. If it's earlier on, I actually wouldn't disrupt the surface of the eye. I would just wait and do the laser. If it's later on and there's fair disease, I wouldn't wait. That patient needs treatment right away.
Okay, I think I agree with that. Just curious, of the doctors on the panel, who does SLT as first-line treatment? Who does drops? All right.
Let me give you the answer. I look at first-line treatment slightly differently. When a patient first gets diagnosed, that's a big shock. And they're learning about it. And to your point, I agree, sometimes I just don't like the idea of waiting and not doing something. What does it mean to take a drop every night? You don't know till you try it. So to me, the definition of first-line treatment is, do you do the laser, let's say, within the first month of diagnosis? And let me explain. So on that first visit, we go over the options. Now, some patients will come in, I read the booklet, I want SLT, okay, fine. But that's not that common in my practice. I'll say, look, we're going to try you on this drop. I'm going to see you back in a few weeks. We're going to see how you're doing, if the pressure's down, side effects. And now we have a discussion about laser, because now you can compare. And they say, you know, doc, I really didn't take the drop half the time, or, you know, this eye irritated, this and that. And so at that point, then they've had time to consider it. And then they decide the laser. And I think that we want to look at our options carefully. And to all of our clinicians' point, we want to match the needs of our patient.
Yes.
There are some patients, lasers, my God, these are in Star Wars, forget it. Okay, fine, not for you. But most patients want to learn. And how can they really compare till they have that knowledge? And so in my practice, that's worked really well, because then they can say, you know, I don't want to do this every day. If that'll do, I can just sit down for 10 minutes, it doesn't hurt, it may not work, 80% of the time it works, doesn't last forever. With half the time, within 2 to 3 years, it wears off, but with the newer lasers, we can repeat it. Great. And so that's how I look at it.
Okay, great. That's great. I mean, that is the beauty of, I think Ginny mentioned she went to 5 doctors and she had 5 different treatment recommendations. And we go to conferences and honestly, panelists of 5 will have 5 different recommendations. And the beauty is it's different for every person. It's different for everybody's journey. And you really have to speak with your provider and really understand what works for you. And then there's a question here, how long can the eye keep its pressure low after laser surgery? I'll open this up to any of the doctors that want to answer that.
Usually with an SLT, you know, patients want to know that. I say on average about 2 to 3 years, and if need be, we can always reapply it. But I would say ballpark 2 to 3 years, but it depends on the patient.
Okay.
And not everyone responds.
That's right.
So it's rough numbers are 80%, maybe even 85% will have some response, but not 100%.
Agree, yeah. That's the same thing I say to my patients. I'll try SLT first, usually, because of the light trial that was done. And I say 70 to 80% of the patients will respond. If you don't respond, you may need treatment with drops. And this can be repeated if you're a responder. Okay, we're going to keep going. We have a lot of questions here, so I want to make sure we get to some of them. Dr. Richardson, the question is, what part of the eye is the faucet that requires to be drained?
So, yeah, it's unfortunate I didn't have a laser pointer to point it out. The faucet is the ciliary processes. So basically in that image that was shown earlier with the blow up of the angle, behind the iris, right next to the lens, there are these little fingers that stick out from the wall of the eye. And these little fingers produce fluid, right? And that fluid basically swishes around inside the eye, It's got nutrients in it, supplies everything the cells in the eye need to have, and that fluid then collects the waste products, and then it leaves the eye, has to go through the pupil, so in front of the lens, underneath the iris, and then out into the angle. So the actual fluid production area is very close to the area that it has to drain from, but to get from the fingers to the angle, it has to go through the eye, around the lens, through the pupil, and then out through the front of the eye. Now, you were mentioning some of the treatments that actually focus on those finger projections. Endocyclophotocoagulation, which can be done at the time of cataract surgery or after, later on, as long as the natural lens is out, actually works to shrink those little finger-like projections to decrease the amount of fluid that's produced. It's really one of the only surgical treatments, really, that focus on the production. All of the other surgical treatments focus on the drainage. And so, it's a good question in terms of the focusing on production versus drainage, because if you can, through medications, surgery, if you could actually get both mechanisms addressed, there's always the potential for synergy, meaning that the two together can work better than just the addition of the individuals. At least that's our hope.
Okay. All right. I'm gonna switch focus a little bit back to the patients. I know you guys really love that. So I want to know, and this is a question from me, not from the audience, but what is it during this whole journey that you've had that has helped you cope best with the disease process, the multiple doctor visits? What is it that's helped you in your life?
Go ahead, Nina.
Yeah. Well, for me, I think that it's the support of family, friends, people who accept me and understand what I'm going through and give me the ability to discuss and to be frustrated when I am, which I am frequently. And having doctors that I have real confidence in. I've been with the same doctors for about 16 years now. And because I do have confidence in them and feel that I can ask them any question, that they'll give me straight answers, that they'll help me understand what to anticipate as much as that is possible. That's really the main thing. Having that support, both on a personal level and a medical level, has been really, really important for me.
Thank you.
Yeah, as well. And having support around me is really vital for me every day. I think also what really helps me get through the journey is that the more I learn about glaucoma, the more I research, like the doctors were saying up here, there's always something new coming out, and it makes me hopeful that, maybe someday they'll find a cure for glaucoma, or as each year goes by and more research is done, that we'll have more MIGs, we could say, something that can actually help glaucoma not become as devastating as it can become to us as we grow older and our optic nerve kind of just fades away. Maybe they'll find another way to treat glaucoma. So I think that as I read about research and I hear about all these new techniques and new drops, I feel hopeful. And that brings me a lot of hope, and I feel encouraged that as time goes by, it's going to get better instead of getting worse. So that has helped me a lot. Yes. I don't know if that's okay.
That's great. Thank you.
I don't know if this would be helpful or not, but kind of maybe a global strategy on what if I had glaucoma, how would I approach it? We want to save your sight but we want you to live your life. Most patients with glaucoma, fortunately, are able to maintain useful vision for the rest of their life. Most patients with glaucoma can be managed with topical medications and a combination with in-office laser treatments. Unfortunately, we don't win all of our battles, but we do win most of them. So as you look at this data and you power yourself with this information, I want you to also give yourself permission to enjoy your life. You know, we want to partner with you. You know, I will never turn down a question from a patient. I heard about some new treatment. I want to know about it. I want to learn about it. That's why Glaucoma Research Foundation has Glaucoma 360, New Horizons. We have a panel. We bring in all the small companies, all the newest ideas, because we want to know about it. But if we're using that plane analogy, let's go ahead and get on the plane, let the pilot fly. You can watch. Now, when turbulence hits, that's different. When all of a sudden you're having trouble, that makes sense. Hey, if there's another pilot, someone sitting nearby, like, what are we going to do here? Strategically, you do better if you have one focus center as your main data collection. For doing your field tests, all these imaging stuff, it's easier to do comparison. Now, get comfortable. You want to find a good partner because this is a chronic disease. Now, if all of a sudden we are having some trouble, if you have the right partner, they will not get angry. They will encourage you to get a second, third, or fourth opinion. Go do it. And then bring it back. You follow me? So strategically, develop a practical, convenient main center of treatment. And most of the time, it's going to be smooth flying. It may not get you that second drink. But if then all of a sudden you're having to make some more difficult decisions, all of a sudden we have to make incisional surgery, you're having side effects, this and that, then that makes sense. Now, you can't go to a meeting without a little bit of homework. I said we do well the earlier we diagnose this disease. If you have glaucoma, the best gift you can give to your family members is the gift of sight. Tell them about your glaucoma. The most effective way for screening for glaucoma is telling other family members. Now, you may not have anything else to talk about, but when you get together for the holidays, at least mention to them that, you know what, I have glaucoma. And you need to get checked by someone who is knowledgeable, who will not only check the pressure, but look at that optic nerve to make sure that you do not have it. We have our own homework. The common theme of all the treatments was insurance. I'm going to ask a question. Has anyone been able to avoid any problems with insurance companies and medical management? I don't see a single hand going up. So for next year's Glaucoma 360 New Horizons, we literally in the last few days have had yet another meeting where we're trying to put a panel together to get the tips, tricks of how patients can navigate the insurance maze. Because there are tricks to it. Unfortunately, sometimes you have to be very persistent. We may sometimes have to partner with you writing letters. Yes, this drop is needed. Yes, they had side effects. But this is a real concern. I think any clinician, that's one of the biggest problems we have is we have a solution, we know what we need to do, but in some corner conference room they decided, well, they don't need that really. And so we're developing actually a panel of experts to help keep us up to date on how to give you information so you can get what you need when you need it.
Yeah, I mean, I think that one of the things in our forums that we have recently is a discussion of some of the insurance companies not wanting to cover the minimally invasive surgeries that we talked about, the canaloplasty, the goniotomies, and we as physicians have been fighting for it. And I think that if there's anything you can do as a patient to call your insurance company or get involved or call your representatives and to voice, especially if you've had the surgery and it was effective and got you off drops, those things are really important. Otherwise, they will continue to cut that, and then we can't offer that to every patient. So,
and your voice really counts. You're the customer.
yeah.
They're not treating you well. Hey, I'm changing insurance companies. And so, you know, you ultimately, we basically try to help you, but you have a lot of impact on that.
Yes.
And so if insurance companies hear enough, hey, oh yeah, the other person had a good result, decreased risk. So that's where, as a team effort, I think that'll help us move the ball forward.
Yeah,
And
absolutely.
what I would like to do is, I know they just said it too, but I want to hammer that point home. You guys have the most important voice, okay? There's only so many doctors. We only have so much time. It's basically attrition, right? but voices coming from you makes the biggest difference, especially what Dr. Bedard was saying about CMS and mixed procedures possibly not being covered. That's an actual battle we're trying to fight right now, because these things that even that I talked about may not be covered at all. So please speak up. You're speaking up for yourselves, but if you don't do it, there's only so many of us. It really comes from you and for you, your family, and everybody else that's going to be diagnosed with glaucoma. Please do it.
Just a quick add-on to that is, these denials that you're going to get from your insurance, whether it's for medications or for surgery, I always emphasize to our patients who get the denials, that initial denial is not final. It is almost always appealable. Okay, their view is it's very easy to send out this piece of paper that says, nope, we're not going to cover it, right? Most people will just accept that, and then the insurance company saves money. But if you appeal it, if you go through the process of the paperwork, if you call your physician, my nurses, most of the time that they spend not helping me with patients is actually trying to get approval. And we are happy to do that, right? Because if this is something I'm recommending to my patient, it's worth taking the effort to get it approved. We don't always succeed, but in general, your physician staff will help you with that where they can, but there are limitations. It will take some work from you. You can't just expect that the office is going to do all the paperwork. Sometimes the insurance company that you're paying your premium to, they care more about what you do or think than what we do or think. So it's an active process that requires both doctor and the individual with the condition. But you can get many of these things overturned.
Yes, and if you want to know more ways of getting involved in active, ask one of us, and we will direct you to patient advocacy programs. Okay, so we're going to do a quick, not rapid fire, but because there are a lot of questions, so I'm just going to, in 20 seconds, give me your answer, and I'll just pick on whatever doctor either is highlighted here or I want to pick on. Dr. Taymorian, you're up to bat. A canaloplasty I had years ago means I can't even try having a stent in that eye. Can you address this type of concern with regard to future treatment?
Yeah, we're looking at different options of diverting the fluid to different compartments of the eye. So again, much like that eye being a plumbing problem, instead of diverting it through the place where the canaloplasty was in, we're looking at ways of diverting it elsewhere. So stay tuned.
Okay, great. That was a good, quick answer. All right. Okay, Dr. Ewok. Advice for patients with low tension glaucoma. Very disconcerting to have eye pressures of between 10 and 12 on each eye and still be experiencing vision loss. You can take more than 20 seconds if you want on this one, but any advice, treatment-wise or anything else, really?
Get a second opinion.
Get a second opinion is the advice. Why is
And
that?
low tension, normal tension glaucoma. In fact, the Glaucoma Research Foundation funded the first international study on normal tension glaucoma, which showed that, in fact, lowering eye pressure in that entity does make a difference. And the question is, there's a difference between normal and safe. Normal is you take a bunch of people together, you do a statistical analysis, 16 and a half, but what we customize is for that particular eye. And so there's, for example, simple factor, the thickness of your cornea, the front wall of the eye, it can be a different thickness. So if you have a very, very thin cornea, the instrument reads 12, it's not 12. The actual pressure is higher. So the bottom line is sometimes you have to get the pressure even below 10. But the risk, the challenge is the lower you go, the more the inconvenience and risk. So you're balancing these two factors. But the bottom line is if your current plan of management and you're losing vision, something's got to change. And sometimes a fresh set of eyes looking at it may help see things differently.
Absolutely. Always advocate for yourself and get a second opinion. If something is progressing, maybe it's something else happening. And I have seen patients come in with multiple drops, many drops, all kinds of, and sometimes the drops are causing issues. Sometimes the drops making the pressure higher. So it's like a reset. And I do recommend that for everybody.
And actually, just to follow up on your thought is, if something doesn't make sense, you look for other possible causes.
Yes.
And so, if you've done all the right thing, most of the time we can win this battle. Not always, obviously not always, but we usually can figure out a way to do it. especially if we catch it early. And if things aren't adding up, there are other medical conditions that can affect your field testing, your side vision. And so you get a team approach to make sure you're not overlooking anything.
Absolutely. Okay, Dr. Richardson, we have a question for you. Can the traditional trabeculectomy be repeated if needed, or should it only be done once?
So you can repeat a traditional trabeculectomy, sometimes through the same site. Sometimes you can rejuvenate the bleb, revise it, or you can actually go in a separate location in the eye. So it is possible to redo or add another trabeculectomy. You know, whether or not that makes the most sense for the individual really is going to depend on the type of glaucoma, the severity, the history. One has to ask, if the first trabeculectomy failed, why did it fail? I mean, trabeculectomies have a certain rate of failure. Even if everything is perfect with the surgery and you've done everything right as a patient and you don't have any other risks, sometimes it just happens. And if that's the case, it may be reasonable to try it again on the same eye. On the other hand, if you've got a trabeculectomy that's failed and you have an understanding of why perhaps it failed, and that has not changed, and doing it again shares that same high risk, then it's likely that you'll be better looking at other surgical or non-surgical options rather than repeating the trabeculectomy. So it can be done for most individuals, but whether it makes sense is very much something that you and your surgeon will need to discuss.
Okay, good. A follow-up question for you, Dr. Richardson. Most eye drops use BAK as the preservative.
Yes.
Do you have patients with preservative allergies that are able to tolerate non-BAK preservatives? And what are those preservatives and what drops have those?
Yes, there are drops that are both preservative-free, and then the non-BAK, such as with alpha-GAN-P, is one option. My experience is that most of the patients who are sensitive to BAK, it is the BAK, and so they are able to tolerate these other, not preservative-free, but they're essentially disappearing preservatives or another chemical formulation, and it's because they are a completely different chemical than BAK. And this is something that, you know, sometimes it takes some education, because if you read the package of these, they are preserved, but it's with a disappearing preservative or something like that. And once you've had a BAK reaction, it's understandable that an individual would be very hesitant to try anything that was not truly non-preserved. But in general, they are worth giving a try, in my experience.
Good. I'm going to answer one question here so I can get through as many of these as I can for everybody. It's an easy question. I saved that one for myself. It's the benefit of being the moderator. What are your thoughts on using a bandage contact lens to protect the lid from sutures post-op? Because you mentioned that the sutures can hurt as you're blinking while it's healing. And this patient said, my biggest challenge post-surgery has been stitches. And I think that the answer is yes, you can use a bandage contact lens to cover some surgeries. You have to ask the doctor, and it depends on the surgery. Because if you're getting a trabeculectomy, we don't necessarily want a regular size contact lens that you would have at home or, on that eye, because the diameter of that contact lens might interfere with the surgery. But there are large ones available in our office that we can use. The other thing is when you have a contact lens on your eye, you are at risk for infection. So that definitely is not something you would decide. We would decide, we place it on your eye, and then we change it out ourselves while you're on an antibiotic. So I just wanted to answer that. I don't know if anyone needed to add anything to that. I don't routinely put bandage contact lenses on. I try to avoid it. I want to just do minimal as I can, but it's definitely an option if that's something that really bothers you.
And also, if there's for example, if for some reason one suture is bothering you, even in the office, we with our we're surgeons, we can clip it. There are other tricks we can do, and also you can use some lubricants. The most superficial sutures eventually typically fall out, so just to buy time, talk to your surgeon about that, but we can mitigate. There are other tricks we can do to get you more comfortable.
Okay, good. All right, over-the-counter allergy medications and drops cause my eye pressure to slightly rise. Is that possible? That's a big question, but Dr. Taimourian, I'll have you.
Yeah, usually like steroid medications, that's typically what we use to kind of quiet things down. That's what you want to be most cautious about. I think there are some other medications that are like antihistamines. Only for particular types of glaucoma would you be concerned, but I would really try to avoid anything with the steroid in it. And look, steroids make your body feel good when something is aching, but they can cause other issues in the eyes. But there's a small set of patients where it's steroid-induced glaucoma. They're using steroid for a particular reason, makes their eye pressure go up really high. So be cautious of what steroid you're using, and that's not necessarily just a steroid eye drop. Any steroid can do that, whether it's an inhaler or a cream. These things do occur. I've had patients come in who've been on just topical steroids for skin problems, younger kids that have come in, their pressure's sky high. It's like, what's going on? I'm using a steroid, but I didn't think it would bother me. It's just a cream that I'm using. Yeah, it did. So anything with a steroid in it, you want to be cautious of.
Okay, great. Well, I think this really winds down our session on the treatment roundtable. We have many, many questions. Again, we'll try to incorporate that into future sessions, or I'll try to sprinkle that in throughout the day today. But I really wanted to thank the panelists, the doctors, and of course our two lovely patients who made the trip out here and are helping and inspiring and empowering our patients in the audience. So thank you.
Yeah.